So good morning, dear students. Today's subject and the topic is tongue, something about the sublingual region and also the supra and infrahyoid muscles. Regarding the tongue, tongue is a very powerful muscular structure that it's forming the floor of the oral cavity and also somehow is forming the anterior wall of the oropharynx. The tongue, as we mentioned, it's a powerful muscular body. It has a motor function for the mastication, for the swallowing, and also for speaking. Also, regarding the sensory innervation of the tongue, is playing a role for the taste, for perception of the taste, and the fine tactile discrimination, the sensitive innervation that we are going to discuss. Basically, the tongue, we are dividing them to different parts. The posterior part, which is, as a matter of fact, this is the posterior 1/3 of the tongue it is. It's called the root of the tongue or radix. And the other part, it's the body, which is the most anterior part behind the incisor teeth, is apex. And the rest, which is considered as the anterior 2/3 of the tongue, it's called body. So the main part of the tongue, there are the root, the posterior part, posterior 1/3, the apex, which is the anterior one immediately behind the incisor, and the body, which is making the anterior 2/3 of the tongue. Some literature, you can say that the part that is in the lateral side of the tongue is called the margin of the tongue as well. So the tongue has two surfaces. The dorsal surface that you are looking at, it's the superior surface or dorsal surface that we are going to discuss, and the other side, it's the ventral surface or inferior surface that one by one we are going to discuss. In the dorsal surface, you see a very important groove, which looks like a V, is a V-shaped groove or furrow. And this groove is called the sulcus terminalis or terminal sulcus. And this terminal sulcus, which looks like a V shape, is dividing the tongue to the posterior part, which is called the pharyngeal part because it's toward the pharynx. And this is, as a matter of fact, is making a root of the tongue, and it's the posterior 1/3 of the tongue is considered the pharyngeal part, and the anterior 2/3, which is here in the dorsum of the tongue, it's called the oral part here, and which is the anterior 2/3. In the middle of the tongue, if you pay attention and if you see, there is a shallow groove or sulcus, which is the median lingual groove, or the median furrow is called, and is dividing the tongue to the right side and left side. And if you continue deep from this groove, you are continuing as a midline septum, which is the connective tissue, which is separating totally the tongue from the in the right and left side. So in this case, the fiber, the muscular fiber, they are not crossing over the tongue. So the tongue is absolutely by this septum, the median septum, or midline septum, is dividing to the right and left, and no fiber or very, very minimum small fiber that are penetrating this septum. Another interesting thing in the dorsal surface of the tongue is at the apex of this V-shaped sulcus terminalis is here. There is a foramen which is called foramen secum. This foramen secum, as a matter of fact, is the embryonic remnant of the passage of the thyroid gland during the development. So the thyroid gland from here is descending down to the neck region as a thyroglossal duct, and in some people you have the persistency of the thyroglossal duct and from the which is connecting the tongue to the thyroid gland. So this foramen secum that you have it in the apex of this V-shape sulcus terminalis, here is the embryonic remnant of the thyroid gland, respectively is the thyroglossal duct. Finally, the pharyngeal part, or the posterior one-third of the dorsum of the tongue, you can see some structure that they are lymphoid structures. So that's why they call it lingual tonsil. They have the same structure that is the lymphatic structure that you have a palatine tonsil, that we said that is between the palatoglossal and palatopharyngeal arch you have. You have a similar tonsil, or of course the shape is different, in the root of at the root of the tongue in the posterior aspect or pharyngeal part and the dorsum of the tongue, and is the lymphoid tissue. So it's the first defense mechanism when you are eating some food, and with this food you have some bacteria or some foreign body, you have it. So those are the first soldiers that they are attacking this bacteria, because the content of this lingual tonsil, it's the lymphatic tissue, and it's important for the defense mechanism of the body. So be careful, only the dorsal aspect or posterior one-third of the dorsum or superior surface of the tongue has the lingual tonsil. This body, or the anterior two-third, it doesn't have tonsil, it has papilla that we are going to discuss. So as we mentioned, here is the anterior two-third of the tongue, which is immediately is in front of this terminal sulcus. And here, very nice, you can see the foramen secum. So in this case, this anterior two-third is called oral part or perisulcal, because there's in front of this terminal sulcus portion of the tongue. And it's the inferior surface of this part is connecting by the lingual frenulum to the floor of the mouth. The dorsal lingual mucosa, there is no underlying submucosal is located there, and on the dorsum of the tongue you can find several papilla that they have according to their shapes. They have the different name, and that's why if you touch the dorsum or superior surface of your tongue, you will feel this roughness, especially, for example, if you have a cat and you touch the tongue, it's very rough, and this is because of the papilla that you can find it in the surface of the anterior two-third of the tongue, only anterior two-third of the tongue. The posterior one-third, which is the pharyngeal or postsulcal portion of the tongue, it doesn't have papilla, it has just palatine, it has just lingual tonsil. Regarding the innervation, we are going to discuss, because it's arising from the first pharyngeal arch. So the innervation, the sensitive innervation of the anterior two-thirds of the tongue, is by the branch of the mandibular nerve, which is the lingual nerve, very important for the sensitive innervation of the tongue, the anterior two-thirds. The posterior one, which doesn't have papilla, and it contains the palatine tonsil. It has the same mucosa that you have in palatine tonsil, pharyngeal wall or epiglottis, which is here. And innervation, since the innervation of the posterior one-third is innervated by the glossopharyngeal, and a small portion in the center is innervated by vagus nerve. So the sensitive or tactile or general sensation of the tongue, it's innervated by three nerves: the lingual nerve for anterior two-third branch of mandibular nerve, the posterior one-third mainly by the glossopharyngeal cranial nerve number 9, and only a small center of the posterior aspect of the root of the tongue is innervated by the vagus nerve, cranial nerve number 10. There are some folds that you can see, and it's connecting the root of the tongue to the epiglottis that for sure you have seen it in the dissection or you will see. And these folds, they are called glossoepiglottic fold. And as you see, we have one in the midline, which is called median glossoepiglottic fold, and two in the lateral side, which is right and left, the lateral glossoepiglottic fold. And between these three folds, you can see a fossa, which is called epiglottic vallecula. This is the fossa when you are eating some food and you are chewing, the food is going backside and it's accumulating here in the epiglottic vallecula and is ready for the swallowing. And when it's swallowed, so the epiglottis is pushing downward and closing the passage to the larynx, which is the respiratory tract, and the food is continue to the pharynx, and then it's going directed to the esophagus. As we said, in anterior two-thirds of the tongue, in the dorsal surface or dorsum of the tongue or superior aspect of the tongue, you have a lot of papilla. And these papilla, we are classified them to four main groups. The first one, which is the biggest one, and it's located exactly in front of the terminal sulcus. It's called circumvallate, or sometimes it's called vallate papilla. And here is the enlargement of this circumvallate or vallate papilla, and you can see at this papilla you have the taste buds. So they are also responsible for the perception of the taste in this case, that we are going to discuss. The other one is the fungiform. The fungiform papilla, they are mainly in the posterior aspect, and the marginal aspect of the tongue, of the dorsum of the tongue is located, and they have the mechanical receptor, thermal receptor, and also the taste buds also. Then we have the foliate. I just jumped from the filiform, the foliate, and foliate is usually near to the terminal sulcus, is in the margin and the lateral aspect of the tongue is located, and as you see also it has the taste bud. So the only papilla that it's the numerous amount of this papilla, which is called filiform papilla, is like a thread shape or conical shape that you have it on all over the dorsum of the anterior two-thirds of the tongue. This is the papilla that, and it's the only papilla that it doesn't contain the taste buds. So in this case, it's covered by the keratinized epithelium. So this is the exception, and the other papilla, as you see, they are containing the taste buds. So this is the details of this papilla that we discussed already. So as we said, the largest part, it's the circumvallate or the vallate papilla. It's around 8 till 12 is variation in different people, but it's exactly in front of the sulcus terminalis or terminal sulcus is located, and also it's containing the taste buds. So it's very important for the perception of the different taste. The other one, as we mentioned, is the fungiform. It looks like a mushroom shaped, and it containing the mechanical thermal receptor and also taste buds. The filiform, we said that is the conical shape or thread shape projection, that it doesn't have taste bud, and the foliate, which is located usually near to the terminal sulcus of the tongue, mainly a little bit laterally, accumulating this foliate, and they contain also the taste buds. As we mentioned in the salivary gland on Thursday, we said that in the tongue also we have a small salivary gland. One of them, two of them is very important. One of them is the largest one, which is located in the apex of the tongue, in the inferior aspect of the apex of the tongue, and it's called apical or anterior salivary gland or lingual gland. And the other one is the small salivary gland, which is located around the circumvallate papilla, so exactly in front of the terminal sulcus, and it's called von Ebner glands, and it's producing serose secretion. And this von Ebner gland, it's producing, by the producing of this serose secretion, is washing the surface of the circumvallate papilla, and then it's preparing this papilla for to be clean, and is allowing it for the new tasting. So when you are eating the different tastes, so it's washed, and then again it's percepting of the salt, sour, or something else, and this is the function of von Ebner gland that we already discussed in the salivary chapter. Just details of these taste buds. Approximately we have 4,600 taste buds, and the structure looks like here. As we mentioned, this taste bud is located and is embedded inside the epithelium of the lingual mucosa of the circumvallate, fungiform, and the foliate papilla, not filiform. And interesting is that you have some taste buds in soft palate and some part of the pharynx. So still, not only tongue, but also the soft palate and some part of the pharynx. Also, they contain the taste buds, and that's why you can have this perception of the taste. As you know, we have 5 basic taste qualities. The 5th one is new, like I think is in the year 2000 they discovered it. You know the sweet, you know the sour, salty, and bitter. And there is a 5th one that it's called umami taste. Umami is like is a Japanese word that it looks like delicate, is the delicious, or like it looks like a taste, the different taste of the meat or fish or some vegetable like a spinach and the other vegetables. So they have a specific name that it has. It's called umami. And also the interesting about the taste buds, their lifespan is approximately 12 days. So that's why near to these taste buds you have the basal cells that they are regenerating the new taste buds, and that's why every approximately 12 days you have the new taste buds, which is responsible for the differentiating of the new taste. And it was when I was a student, or it was a long time ago, so they were telling us the exact localization of the tongue, that the tip of the tongue is for the special for perception of the special kind of the taste, bitter, for example, in the backside of the taste, this. And nowadays, according to the new research, there is no specific localization that this part is for sour, this part is for the salty or something. This is the new research that there is no specific taste qualities in the place of the tongue. So wherever in the tongue they are approximately is equal for this perception of the these 5 basic tests. Regarding the inferior aspect, or we can say the ventral aspect of the tongue. So when you raise your tongue and you look at under the tongue, you can see that this inferior aspect, or the ventral surface, it doesn't have papilla. Yes, papilla is just located in the dorsum or superior aspect of the tongue, only in anterior 2/3, and the posterior 1/3, which is behind the sulcus terminalis, is just contain the lingual tonsile, no papilla. Yes, so. But in addition, instead of the papilla, we have another or several folds. One of them is in the midline, which is called lingual frenulum, or the frenulum of the tongue. Yes, lingua, glossus, all it means that we are talking about the tongue. So lingual frenulum, or the frenulum of the lung, is the continuation of the mucus covering from the floor of the oral cavity that is going to the ventral or inferior aspect of the tongue. And if you continue in this midline deep, you will reach to this midline sagittal septum that we said that it's dividing the tongue to the left and right. In each side of the frenulum, if now when you go home and you in the mirror you look at your inferior aspect of your tongue, you will see lateral to this frenulum the bluish color. This bluish color structure is the deep lingual vein that is easily under the mucous membrane. You can see it, and is one of the venous drainage of the tongue. Is this one. And lateral to that, again, is another fold, which is also the embryonic remnant. It's the fimbriated fold, it's called. So those are all in the inferior aspect or ventral aspect of the tongue you can find. In the floor of the mouth, as we mentioned, you can, very nice, you can see this sublingual fold, which is a place for the opening of the minor sublingual ducts, that there are several. And here, in the two sides of the frenulum, you can see the sublingual caruncle, they call it, or the sublingual papilla in some books. They write it exactly in the two sides of the frenulum, and this is the place for the opening of the submandibular duct, and the major sublingual duct is open in this region. Right now, 5 minutes ago or half an hour ago, I have a patient here that it has a stone here inside the duct, and this stone, it's preventing the flow of the saliva, so the saliva stay in the place, so then it will be bacterial infection, and then when you press, so the pus is coming out instead of clear saliva, so the pus is coming out. So this is, for me, exact diagnosis of the inflammation of the salivary gland, and we have to treat it, remove this stone, and treat the cause and treat the inflammation. So all of this is the clinical importance for you. A very important part of the tongue, as we mentioned it in the beginning, is a muscular structure, this tongue. And the muscles of the tongue, we're dividing it to the intrinsic or intraglussal. It means that they are originated from the tongue and they are inserting to the tongue. Yes, origin and insertion is the tongue. And extrinsic or extraglussal muscle, that they are originated outside of the tongue. It means some bony structure around the tongue, and they are inserted to the tongue. Yes, and as I mentioned in the beginning, at the tongue, in addition of this mucosa, papilla, and folds and those muscles, we have two dense connective tissue. One is exactly on the dorsum of the tongue, and this whitish color, this is called lingual aponeurosis. This is the lingual aponeurosis, and the other one that we mentioned it also is this septum, the lingual septum, or the midline sagittal septum, which is divided along to the left and right. And these two very dense connective tissue, the lingual aponeurosis and the lingual septum, they are the place for attachment of all these muscles. Yes. So the extrinsic muscle, first we are going to start. It's the muscles that they are, as we said, they are attaching to the specific bony site outside of the tongue, and they are inserted in the tongue. And generally, the function of this extrinsic muscle is moving the tongue as a whole. Yes, you move the tongue upward, you move the tongue downward, retracting the tongue backward, protruding the tongue outside. So all of them is because of this extrinsic or extraglussal muscles. And there are 4 muscles that we are going one by one. One of them is styloglossus, which is originated from the styloid process. The other one is the hyoglossus, which is here, originated from the body and the greater horn of the hyoid bone. going upward. The other one is the genioglossus, which is originated from superior, thank you very much, superior mental spine in the internal surface of the anterior aspect of, or the symphysis part of the mandible. You have two spines. One spine is superior, is for the attaching of the genioglossus, and the other spine is the inferior spine, which is for attachment of the geniohyoid muscle, which is the suprahyoid muscle. Yes. So this is the table that prepared for you for the all this extrinsic lingual muscle, or the muscles of the tongue, origin, insertion, innervation, action. The genioglossus is the, as you see here, it's the most bulky muscles of the tongue, and it's, as we said, that it's originated from the superior genial or the superior mental spine. The function is very important, that is protrusion of the tongue. It means pulling the tongue outside. If it's working bilaterally, so the tongue is protruding in the midline, yes? But if one side is paralyzed, with any reason it didn't have a good function, so the tongue is deviated to the other side, it means to the side of the paralyzed part that I'm going to show you. Another one, for example, the hyoglossus, which, because it is originated from the hyoid bone, the greater horn and the anterior part of the body, and is going to the lateral aspect of the tongue, is by contraction is depressing the tongue. Styloglossus, because it's above and is originated from styloid process, it's elevating and retracting backside of the tongue. And be careful, I mentioned it Thursday about in the soft palate. There is one muscle that we consider it as a muscle of the soft palate. And also I said that is considered as a muscle of the tongue, yes? So palatoglossus that we already discussed. And it's interesting that you see that all the extrinsic muscles of the tongue is innervated by the cranial nerve number 12, which is hypoglossal nerve. And this is, that is a palatoglossus, and we said it, that is considered as a muscles of the soft palate and also muscles of the tongue. It has a different innervation like other popular muscle of the soft palate, except the tensor belli palatini, which is innervated by the branch of the vagus nerve, which is making the pharyngeal plexus together with the cranial nerve number 9. So this is the extrinsic muscle, and about the function of this muscle we already discussed. So one by one, I will show you this important muscle. The genioglossus. Here is the genioglossus. As you see, it's the function or the examination of this muscle. It's you just ask the patient to pull out his tongue from the mouth, or protrusion of the tongue. And you can check the function of muscle and the function of the hypoglossal nerve. So normally it's protruding in midline, but it's not working if one side, so the tongue is deviated to the paralyzed side. Be careful, it's deviating to the paralyzed side. So this is the slide that it can show you if it is both sides, the bilateral function of this muscle, the genioglossus muscle, working. The tongue is coming out of the mouth in midline, but for example, if the left side, it doesn't work with any reason by the paralysis of this side of the hypoglossal nerve, for example. So this muscle, the right muscle, it has normally functions and is stronger than the other side. So this strong muscle is pushing or pulling the tongue toward the paralyzed weak side. It means that the deviation is always toward the paralyzed side. This is very important for the examination of the hypoglossal nerve, cranial nerve number 12, and also functioning of the genioglossus muscle. And be careful, we are going to discuss it in the central nervous system, that we have two lesions in the neurology. We have the lower motor neuron. It means that when the nerve is in the periphery, it means that it's coming from the central nervous system. So if the lower motor neuron of the cranial nerve number 12 is affected, so then the same side, it means the ipsilateral side, is paralyzing the hypoglossal nerve. And in this case, the protrusion of the tongue, it goes to the paralyzed side. Be careful, in the central nervous system we are going, if it is upper motor neuron lesion, it happened. It means somewhere in the cortex of the brain, via, for example, the brain stroke, it become the nucleus of the parasympathetic, the nucleus of the hypoglossal nerve with damage, because the nerve, they are from the cortex, most of them, they are crossing. So right side, it goes to the left side, and left side, it goes to the right side. If I have a brain stroke in my right hemisphere, which is the location of the nucleus of the hypoglossal nerve, so the paralyzed nerve in the periphery, it will be in the left side, yes? So this is the difference between the upper motor neuron lesion and lower motor neuron lesion that pay attention, that we are going to discuss in the chapter of the central nervous system. Next muscle of the extrinsic muscle of the tongue that is important, and it's passing through a gap. There is a gap which is called oropharyngeal triangle. The oropharyngeal triangle is this gap, and this is the gap between superior constrictor muscle of the pharynx, middle constrictor muscle of the pharynx, and the mylohyoid muscle, respectively, is the posterior aspect of the mylohyoid muscle. So here, there is a triangle which is called oropharyngeal triangle, and through this triangle, it passes the several structure, and one of them is the hyoglossus muscle, and the other is the styloglossus muscle. So here is the hyoglossus muscle, is the pathway of the hyoglossus muscle, and as you see, comparing to genioglossus, it's located laterally, but containing the styloglossus that we are going to discuss is medial to that. And this is very important landmark, the hyoglossus muscle, because, for example, here is a very important artery in the region of the lingual region and sublingual region, which is called lingual artery, and according to its name, it's clear that it's the main blood supply of the tongue, yes. And this lingual artery that we are going to discuss is passing through this oropharyngeal triangle, and it's going upward, and is making a loop, and it's going deep to the hyoglossus muscle. So this is the lingual artery. Glossopharyngeal nerve, which is the cranial nerve number 9, also it's deep to the hyoglossus nerve. It passes. The two nerves, which is the hypoglossal nerve and the lingual nerve, they are passing in the external surface of the hypoglossal nerve. This is very important topographical relationship of this important structure when you are operating in this area. So you have to know the nerve is passing external to the hyoglossus or internal to the hyoglossus muscle. Styloglossus, as we said, is in addition of the hyoglossus, is the other muscle that is passing through this gap, the oropharyngeal triangle. And this gap, as we mentioned, is between superior constrictor, middle constrictor, and the mylohyoid muscle. So two components of this gap, the oropharyngeal, is hyoglossus and styloglossus, and some blood vessels and nerves that I am going to discuss. And palatoglossus, that already we discussed, is the muscle of the soft palate also. We said it's making anterior and lateral arch, which is called the palatoglossal arch, and it's making the anterior border for the tonsillar region, for the palatine tonsil. The posterior border is by this arch, which is called isthmus facium is this one. Is the connection between oral cavity with the oropharynx. But this arch, which is making a posterior border for the palatine tonsil, is here is the palatoglossal arch. Here is palatopharyngeal arch, which is the same name. We have palatopharyngeal muscle. So this is the two. We already discussed on Thursday about the function of the palatoglossus in the soft palate chapter. It's elevating the backside of the tongue. It means elevating the root, and also it's closing the isthmus of the paucium by taking this arch toward the medially. It's like a curtain that you close it, and also it's playing role for the depression of the soft palate. And as I mentioned, it also is the only muscle of the extrinsic muscles of the tongue that is not innervated by the hypoglossal nerve, but is innervated by the branch of the vagus nerve, which is take part to the formation of the pharyngeal plexus, which is mainly the glossopharyngeal and vagus nerve. That was about the extrinsic muscle, and this is the intrinsic muscles of the tongue. And as I mentioned, the intraglossal or intrinsic muscles, they are the muscles that origin and insertion is the tongue. And this is very nice. You can see the lingual aponeurosis, which is on the dorsum of the tongue. You can see is a dense connective tissue. And another, it's the lingual septum, which is dividing the left and right side of the tongue. And this intrinsic muscle, they have a function which is altering the shape of the tongue. Yes, extraglossal, it was moving the tongue as a whole, but somebody that is looping his tongue, is folding the tongue, or is making a shortening of the tongue. So those are the altering or changing the shape of the tongue. Those are the function of the intraglossal or intrinsic muscles. So it's these muscles that are important, again, for speech, for eating, and for the swallowing. According to their direction, we divide them to 3 or 4 groups. The passage of the fiber that is going longitudinally, this is the frontal section, so here is the longitudinal intrinsic muscle. This longitudinal, we divide them to the superior and inferior group. Here, as you see very nice, you can see a transverse muscle, and here is the vertical muscle. So according to the direction of the fiber, so the longitudinal superior, longitudinal inferior, the transverse, which is, you see that it doesn't penetrate the septum usually, maybe some small fiber, but it's separated from each other, and the vertical one. And here you have the table that it's for the details. And as you know, the superior and inferior longitudinal muscle of the intrinsic lingual muscle, they are the superior one is shortening, or both of them, they are shortens the tongue. Yes, so by the contraction, because it's passing longitudinally, by the contraction is shortening the tongue. And the superior one make the dorsum of the tongue concave, and the inferior is making the dorsum of the tongue is convex. Yes, so it's according to the pathway superior or inferiorly. Transverse muscle, it's the contraction is making narrowing of the tongue. Yes, so it's folding of the tongue or narrowing of the tongue or elongates the tongue. And the vertical is widens or flattens the tongue. And those are all, as you see, they are altering the shape of the tongue, and the innervation of all the intrinsic muscle, there is no exception for this case, and is hypoglossal nerve, cranial nerve number 12. So if I want to do the recapitulation of the muscles of the tongue, is that we divide them to the two groups, the extraglussal and intraglussal. The extraglussal, they are originated outside of the tongue in the bony landmark, and they are inserted to the tongue. The intra one, or intraglussal, they are origin and insertion inside the tongue. All these muscles, they are somehow attaching to this dense connective tissue aponeurosis of the lingual and the septum. And the extrinsic muscles, they are moving the tongue as a whole. The intrinsic, they are altering the shape of the tongue. And all the muscles of the tongue is innervated by hypoglossal nerve, cranial nerve number 12, except one extraglussal or extrinsic, which is palatoglossus, which is also considered as a muscles of the soft palate. Regarding the blood supply of the tongue, which has a very rich blood supply, is very, very important. So any operation or any trauma in the lingual or in the region of the tongue, if the patient has a trauma in the tongue, you see a massive bleeding. It can happen, and this is thanks to the very, very rich blood supply. The main artery blood supply of the tongue, as we mentioned it before also, is according to its name, is lingual artery. Lingual artery is one of the ventral branch of the external carotid artery, which is approximately at the level of the greater horn of the hyoid bone, is coming ventrally from the external carotid artery. And then here, when it's going from the back side toward the anterior side, then is dividing to the main branches. One of the two main branches that is continue, it's the deep lingual artery, which is here, and it's reached to the apex of the tongue. And the other one is the dorsal lingual artery, which is in the beginning, it's giving for the dorsal aspect of the tongue. And the other branch is the sublingual artery, which is here. And this sublingual artery, sometimes it has anastomosis. It means the connection with the other source of the blood supply of the tongue, which is submental artery, which is, as a matter of fact, is the branch of the facial artery, which is itself is another ventral branch of the external carotid artery. It's very important, and sometimes it can substitute this sublingual artery, yes? So that's why, for example, it's important to know that this variation is existing, because if this artery is ruptured, and is normally is a branch of the lingual artery, and you start to do the ligature of the lingual artery to stop the bleeding, and suddenly you can see the bleeding, it doesn't stop because this artery, it's substituted, or it was the main source from the submental artery, which is another branch, which is the facial artery it is. So this is also is important, so that's why in this picture it's showing it, that it has the interconnection of this artery from the different source, the lingual artery and the facial artery. If you go to the details of this pathway of this artery, it's interesting that the lingual artery that we said that is at the level of the greater horn of the hyoid bone is coming, it's going deep to the, as you see, deep to the hyoglossus muscle. In this case, the lingual artery, as we mentioned it, it's passing through this oropharyngeal triangle, the gap between the superior constrictor, middle constrictor, and the mylohyoid muscle. So it's going deep to that, and then it's continue, and it continue toward the apex of the tongue. And here now you can see that the lingual artery is passing between the genioglossus, which is this muscle, and the hyoglossus muscle is going toward the tip of the tongue or apex of the tongue. This artery also, it's supplying, all this artery is supplying the sublingual gland also, which is located in the sublingual region. It's supplying the lingual aspect of the gingiva, it's supplying the oral mucosa of the floor of the oral cavity. So this is the main blood supply that we already mentioned it, and here I have it as a table for you, that lingual artery is the main source, is a branch of external carotid artery, and itself it gives 3 branches, which is the dorsal lingual in the dorsal aspect of the tongue, sublingual in the floor, in the region of the sublingual gland, and the deep lingual, which is supplying the ventral or inferior aspect of the tongue. And it has some terminal branches also that is going and is entering to the dorsal aspect of the tongue and is supplying the anterior 2/3 of the tongue. So except this lingual artery, we have other artery. One of them I mentioned it, submental artery, that you saw it in this picture here. This is also a artery which is supplying the tongue, and the origin of this artery is the facial artery, which is itself is the ventral branch of the external carotid artery. And this is, as here is mentioned, is anastomosing with the sublingual artery and supplying the sublingual gland and the floor of the mouth. The other artery that already we discussed it in the soft palate, it's the tonsillar branch of the ascending palatine artery, which is a branch of the facial artery, which is itself branch of external carotid artery, is responsible for innervation of the root of the tongue. It means the dorsal 1/3 of the tongue. And finally, another artery, which is ascending pharyngeal artery, is also a branch of external carotid artery, which is supplying the root of the tongue. So these 2 arteries, they are the same artery that we mentioned it for the blood supply of the soft palate, mainly in the tonsillar region. So because it's close proximally with the root of the tongue. So palatine tonsil, soft palate, and the root of the tongue. The venous drainage, more or less, has the same name that you have it for the artery, but you have it for the vein, but a little bit is different. That, of course, we had lingual artery and we have lingual vein. This lingual vein here is draining to the main vein of the neck region, which is called internal jugular vein. So here is the lingual vein. But here you have the 2 main source of the vein. So there is always, be careful in the vein, most of the time we have variation. Yes, so it's not 100% what is written. Yes, so but the main 2 source is the dorsal lingual, and the other one, which is here, and the other one is the deep lingual. But the problem is, or the difference is between the artery. As you see, the deep lingual artery is going deep to the hyoglossus muscle. Yes, you see, it's going deep to the hyoglossus muscle, and then it goes to the apex. But here, the deep lingual vein is going external surface of the hyoglossus muscle. So that's why this deep lingual vein, when you look at the mirror in the inferior aspect of the tongue, you see this bluish color that exactly under the mucous membrane you can see this vein. And very interesting is that this deep lingual vein, which is sometimes because it has the same pathway of the hypoglossal nerve, which is the cranial nerve number 12. Also sometimes it's called vein accompanied by hypoglossal nerve. Vena comitans nervi hypoglossi, it's this vein that whenever that the hypoglossal nerve it passes, so this vein is going. So that's why vein accompanied by hypoglossal nerve or vena comitans nervi hypoglossi. So this is the difference between the deep lingual vein, which is externally it passes through the hyoglossus, and the deep lingual artery, which is internally it passes. The other one, which is here, you can see, is the dorsal lingual vein, which is following with the artery, and then it's continue and it's going between the hyoglossus and the genioglossus muscle. So all these veins, so here some books, they write, for example, the sublingual vein, yes? In another slide I will show you. But finally, all these veins, they are draining to the lingual vein, and from the lingual vein, it goes to the internal jugular vein, usually, yes? Sometimes lingual vein is connected with the fascial vein, and they make the linguofascial vein, and then finally, the ultimate destination is the internal jugular vein. It's the drainage of that. So this is the main venous drainage, yes? So this is the inferior aspect of the tongue that I said that if you look at the mirror, you see this bluish color. Here's the region of the frenulum, and here is the deep lingual vein that you can see it. And lateral to that, those folds that you can see, it's the fimbriated fold that we mentioned it. So this is the main venous drainage that is tributaries. It's the deep lingual vein and dorsal lingual vein. Be careful, some books, they write it sublingual vein also. And the other vein, which you had the similar artery, so it's submental vein, which is submental artery was branch of fascial artery, so here submental vein is draining to the fascial vein. And finally, again, the fascial vein is drained to the internal jugular vein. So this is the tongue. The innervation of the tongue, extremely is important for the student. The innervation of the tongue, we classified it according to the different aspects, yes? As you know, and as we mentioned it, the tongue has a sensitive innervation. And this sensitive innervation, we can divide it as a general sensation. General sensation, it means touch. It means cold or hot. It means pain, yes? Those are the general sensations that you can feel it in your tongue, yes? And this general sensation for the anterior two-thirds of the tongue, which is in front of the sulcus terminalis, is responsible for that. It's the lingual nerve, which is branch of the mandibular nerve. This general sensation, it's for the posterior one-third of the tongue, or the pharyngeal part, or the root of the tongue. It's via the glossopharyngeal nerve, mainly, or a small central portion by vagus nerve, yes? So this is the general sensation. And as we said, tongue has taste perception, yes? So we have a specific nerve for the taste, that they are carrying the taste fiber to the different part of the brain for the perception of the taste, yes? This is the different center for example, for the perception of the hot and cold, when you eat some hot food or cold food, yes? So that's why you have a special sensation, because taste is a special sensation, or you can say taste fiber innervation of the tongue. For anterior two-thirds is via chorda tympani, which is branch of fascial nerve. So the anterior two-thirds, as you see, it's different between the general sensation innervation, which is a branch of which is innervated by the lingual nerve, which is branch of mandibular nerve, and a special sensation or taste by the chorda tympani. But be careful, general sensation innervation and a special or taste innervation for posterior two-thirds is staying the same as a glossopharyngeal nerve. And as we said it, and I show it to you in the next slide, only the central portion of the root of the tongue in the back side is a small area that is innervated by vagus nerve. Regarding the motor innervation, which is, whenever we say motor, it means somatomotor. It means that innervating the muscles. And already we said that all the muscles of the tongue is innervated, most of the tongue, all the muscles of the tongue is innervated by hypoglossal cranial nerve number 12, except one exception, which is palatoglussus, which is innervated by mainly vagus nerve through the pharyngeal plexus, which is formed by 9 and 10. Yes? So this is very important, and it's usually the subject of the question. And this is what I was explaining to you, and this is the only central aspect of the root of the tongue. Now they discovered that this part is innervated by the vagus nerve. Otherwise, the general sensation, lingual, posterior one-third glossopharyngeal, only this part is vagus. The taste, anterior two-third, chorda tympani, is changing, the facial nerve, not lingual. But the glossopharyngeal is the same for general sensation or somatic sensation and taste, and this part that it's connecting the root of the tongue to the epiglottis, which is glossoepiglottic fold, the median and lateral, and vallecula, all of them, they are innervated by the vagus nerve. But this is now you are outside of the tongue, yes? So this is the connection of the tongue with the epiglottis. So the region of the glossoepiglottic fold and vallecula is purely innervated by the vagus nerve. But what is the structural part of the tongue? It's just this center of the tongue in the root. It's innervated by vagus, otherwise glossopharyngeal and lingual. For the general or somatic sensation and taste, fiber for glossopharyngeal and facial nerve, respectively, the chorda tympani. Very extremely important. Lymphatic drainage also of the tongue is very, very important because the tongue is one of the organs that it has very rich lymphatic drainage, and this is a clinical importance when the patient has cancer of the tongue. That recently is increasing the number of the cancer of the tongue and also the infection of the tongue. Yes. So the different part of the tongue, they have different drainage of the lymphatic drainage. Usually the tip of the tongue or apex of the tongue, it's draining to the submental lymph nodes. The margin of the tongue is usually of the body is draining to the submandibular lymph node. The dorsal aspect or the pharyngeal part or the root or posterior aspect of the tongue is draining to the group of the lymph node that they are, as we mentioned it before, that they are called deep cervical lymph node. And this deep cervical lymph node, you can find it parallel, always parallel with the internal jugular vein, mostly, not always. Internal jugular vein, yes? So we divide them to the superior part, middle part, and inferior part, yes? And this pharyngeal part, it's going to the superior part of the deep cervical lymph node, which is parallel with the internal jugular vein. And since this lymph node is the place that the internal jugular vein is crossing this muscle, what is this muscle? Posterior belly of digastric muscle. So that's why the name of this lymph node is called jugulo-digastric lymph node, because it's the place that the internal jugular vein is crossed over the posterior belly of digastric muscle. It has a clinical name which is called Kittner lymph node. It's extremely important for the maxillofacial surgeon here. And the oral part, it's either directly is going to the submental submandibular region, but also it can goes mainly from the tip of the tongue, not only from the submental, but also it can goes to the other group of the lymph node, which is called jugulo-omohyoid lymph node. Why they call it jugulo-omohyoid? Because the jugular vein is crossing the omohyoid muscle. This is called Kocher lymph nodes. They are extremely important. So, and another important things, lymphatic drainage of the tongue is that interesting is that the lymphatic drainage from the right and left side of the tongue it can go to the same side or it can cross. And that's why, for example, it's common for the squamous cell carcinoma is one of the most common cancer in the tongue, that usually it's from the right side is going to the left lymph node, or from the left it goes to the right lymph node. So it's going to the opposite side. It means the contralateral part, not ipsilateral part. This is also extremely important. And then, of course, because of this importance of the diagnosis, the cancer diagnosis of the tongue has a very, very bad and poor prognosis. Yes, usually the patient die in 5 years. Is very interesting between the tongue and lip. Lip carcinoma, the 95% the patient is survive. Yes, but a little bit the other organ is the tongue. It's 95% is death. Yes, so that's why we classify this lymph node in the neck region. It's important according to the level of the position of this lymph node. We are dividing to the 6th level that definitely the dentistry student will be asked in the 5th year in the state exam, this classification during to the neck dissection. So submental, submandibular is 1, superior, middle, and inferior. Deep cervical lymph node is 2, 3, 4, and posterior part, or the posterior cervical angle is 5, and the anterior cervical lymph node is involved, so it's the 6. So I don't want to go to the detail, just to mention generally that if the lymph node from the cancer is involving in the central position, which is the 2 main central position, you have it when the jugular vein and facial vein, they are joining together. They call it jugulofacial venous junction. This is one of the important places. And the other one is the jugulosubclavian junction, venous junction, which is the central part, it's located. And the other lymph node that you can see, they are in the peripheral part. So this is for doctor is important. If the peripheral part of the lymph node is involved, so usually this disease is localized, yes? So, but if this lymph nodes is in the center, it's involved, so it means that this disease is very, very extensive and it has a very poor diagnosis. So this is the level that how to manipulate and how to manually examine bilaterally always. You have to touch this lymph node, yes? Usually, if you touch your orofacial region, you don't feel any enlargement of the lymph node, yes? Whenever you feel that the lymph node is enlarged, only 2 reasons: infection, cancer, yes? So usually is infection, yes? It can be tooth infection, nose infection, ear infection, orofacial infection, bacterial infection, but another just clinical things that in future it's helpful not only in the orofacial region, any part of the body, yes? If this lymph node is more than 1 centimeter, then you have to definitely negotiate it. What is it? If it is less, so usually we wait, we will see how it will react, or we will treat the infection, or we will find the cause of the enlargement. If the lymph node, when you touch, is painful, usually is inflammation, is infection. If the lymph node, the consistency you've touched that is rubbery, it can be a tumor which is called lymphoma. If it is hard, fixed, not movable, fixed with someone, immediately go to the doctor, because most probably is the cancer, yes? So stony, hard lymph node, not movable, and it's enlarged, and is not painful so much, so it is maybe, yes? You don't touch the patient, and you say, oh my God, you have cancer. No. You never tell the patient, since you didn't take the biopsy, you didn't send it to the histology, and you don't have the paper from the histology that it is a cancer, you are not allowed to tell the patient that you can tell it might be something bad, yes, or suspecting of something, but definitely with touching or some visual examination or X-ray examination, you never say the patient, because psychologically you disturbing the patient, and then 1% the result will come and it's benign tumor, for example, or inflammation. So this is important. So that's why we are learning the anatomy. It's not just look at the teeth if you have a caries or not. If this teeth is grayish, then you do the bleaching and you will be nice or something. But it's your duty to find to also to look at the oral cavity, look at the tongue, take the tip of the tongue out, going inferior surface, superior surface, lateral surface, and sometimes the patient doesn't know. You can see in the margin, which is the most common part, anterolateral aspect of the tongue is the place for the squamous cell carcinoma. Yeah? Or there are the risk factors, the cigarette, the alcohol, HPV virus. They are all the risk factor that you can see the different part of the cancer that is growing, and when is in this stage is really, so you have to either total do the glucectomy, all the tongue you have to cut it, or half of the tongue you will cut it, or 3/4 of the tongue you will cut it, and then you have to go through the neck dissection of the lymph node. Since the lymph node is involved, so it's spreading to the body, and then it's not operable. So that's why it's important to follow this clinical examination. So just look at the time. Yes, you don't have.